this is really practical. You can't really keep doing this for a particular infant to a child to an adult. And so the idea is that if you can find a method of a slow release of glucose, you can really fix the problem. So the concept is a simple one, and then you have to move forward. So this is where my mentor, Dr. Chen, started his career with Dr. James Sidbury of the role of uncooked cornstarch in the treatment of hypoglycemia for glycogen storage disease type 1. And so this was a publication in none other than New England Journal of Medicine, and this was, as you can see, in 1984. And today if I ask you what is the treatment for glycogen storage disease type 1, it's still the same. We may have a second generation of cornstarch, but the principle is still the same of a low release form of glucose that would provide a source of energy and allow these children to grow. And today we have many of these children who are adults, and my oldest patient is in his mid to late 60s at this point. So once again, just to touch upon how simple changes can make a very big difference in one's life and in the treatment of these patients. And then you come to the next aspect, that cornstarch, how is cornstarch really broken down? It requires amylase from the pancreas to be available to break down the cornstarch. And so if you're under a year of age, your amylase may not be completely mature. So that's adding to the first concept. And so it may result in gas, bloating, diarrhea. But if you do a gradual, slow introduction of cornstarch, you may reduce the side effects. Or if you start becoming more smart, is if you artificially provide pancreolipase, you can help break down the cornstarch to reduce the side effects and make it available even before a year of age. So once again, building on that simple concept, you can keep growing from it and keep providing better and better treatment to your patients. So now we're going into the next phase of advances. We went from prevention to simple manipulation to now replacement therapies. And I think that concept is extremely clear when we provide cortisol to someone with congenital adrenal hyperplasia, thyroid synthroid or thyroid hormone for hypothyroidism, growth hormone for growth hormone deficiency, insulin to a patient with diabetes, clotting factors to someone with hemophilia, and then you go into the concept of enzyme replacement for other conditions, including the lysosomal storage disorders, and I'll try and close with other disorders as well. So I think you all know about treatments that are available for Gaucher disease, for Pompe disease, for adenosine deaminase deficiency by the use of pegylated enzymes. And I'm going to tell you my personal story of how I got involved in the field and how a rare disease paved the way of understanding for many, many diseases, including the more common diseases like hemophilia. And I hope I can inspire you that get started early. I was exactly a postgrad like you at Duke University when I started my career with this, and I still have a full career ahead of me with complete job security in the United States, no problem. So Pompe disease, as you all know, is also known as acid maltase deficiency or GSD type 2 or glycogenosis type 2. It's progressive, it's multisystemic, and think about each word that I say very, very carefully, because often we think of them as a muscle disorder, but here I'm using the word multisystemic. It's debilitating, it's often fatal, and it's a neuromuscular disease. So I did not say it's a muscle disease. I use the word neuromuscular disease, and you'll see as this talk goes along why I've chosen these words the way I have. And it's caused by the deficiency of this lysosomal enzyme, acid alpha glucosidase, which I'm going to refer to as GAA. And so this results in build-up now of glycogen within the lysosomes, primarily in muscle cells throughout the body. But this disorder encompasses a single disease continuum with variable rates of progression. So depending on the amount of residual enzyme that the patient has, they can present right at birth or they can present much later in life. So until 2006, there was no treatment for Pompe disease, but many attempts were made in terms of supportive care. How could you reduce, maybe if you reduce cytoplasmic glycogen breakdown, if you enhanced it, that is, could you reduce what's building up in the lysosome? So using drugs like epinephrine and glucagon, and I'm going to come back to this concept of how we've now used it again. And then enzyme replacement therapy, but if you don't target the enzyme to where it's needed, in this situation in the lysosome, it's going to be lost and it's not going to be helpful. And so then it's taken up in the liver, but not in the organs where it's needed. We've attempted bone marrow transplantation, but until 2006, the common feature to all these therapies was that none of them really worked and that the infant or the child with Pompe disease died. And so here I'm going to tell you how each patient matters in the so-called rare disease space, where we had this little patient, Carmen. As you can see, this is an African-American baby. And Carmen was about 5 months old when Carmen was diagnosed with infantile Pompe disease. And this was clearly before 2006. So Carmen, over the course of time, started getting weaker, and the family took whatever they could to raise money in an attempt for a bone marrow transplant. So this was a patient that we saw at Duke University, and you can see that his disease was advancing. He was now on tube feeding and also was extremely floppy and weak. And Carmen ultimately was too weak for a bone marrow transplant and succumbed before a year of age. So we had all gone to his funeral, and that's when my mentor, Dr. Chen, and my senior registrar, on the way back, I heard this conversation. This is not going to repeat itself. We are going to find a treatment. So this one patient inspired an entire career of many, many lives and many, many patients for the future. And so then we started to think about bench to bedside and how do we really develop a treatment. And so it can look very daunting because it goes through many, many different steps from the discovery or screening stages to what we call preclinical research. That is, we've got to identify if this works in an animal model before we go into clinical studies. And after it goes into clinical studies, then you've got a new drug application process and a review by the ethics committee, which in the United States is the FDA. And then if everything works out, you go into post-marketing situation. So this process here can take a very long time, and out of say 5,000 drugs that go out, maybe 2 or 3 make it to market. And the other part is that there are different phases of the clinical trials, which I'm sure you're fully aware of. First in man studies, phase 1, proof of concept that a drug is going to work, which is phase 2, then using it in a larger population and in more than one center around the world, that's phase 3. This is what you register with the FDA or the governing body, and then you present your data to the FDA, you present your safety data, and then depending if it's a rare disease, it can go through an accelerated approval protocol, and then you go into the post-marketing phase. So there are many, many steps and many challenges. And so when we started with this concept of a development for Pompe disease, we had learned from the prior mistakes that if you just gave the enzyme without it being targeted to the lysosome, which is where the enzyme needs to be delivered, is going to be of no use. So the hypothesis was we were going to inject intravenously the recombinant enzyme RhGAA with the sugar moiety, mannose-6-phosphate, because this is what is needed to take it to the receptor, the M6P receptor, the mannose-6-phosphate receptor, into the lysosomes, and this would correct the enzyme deficiency in Pompe disease. And so we would use the precursor form of the enzyme, which is 110 kilodalton, which is RhGAA. We were going to add a sugar tag, which is this hatched line here, deliver it via the bloodstream intravenously. It would now go through the various steps, get tagged with the M6P receptor as we talked about, and make its way into the lysosome. So look at the number of steps already we're talking about. Muscle is not easy to traverse, so I want you to keep this in mind, and it's about 40% of the body. So we have to provide enough via the bloodstream that is going to traverse through all this capillary network, etc., and end up in the lysosome. So when we set out, the cost was extremely high to bring the drug to market, and we had no one financing it. As I said, in those days, only 1 in 5,000 compounds were successful. It takes about 15 to 20 years, so I thought here goes my career. And then there are many challenges for rare diseases with lack of sponsors for funding. This landscape has completely changed. So for all of you, this is a very different world. In fact, the low-hanging fruit today is the rare disease space with all kinds of benefits that are provided to allow for accelerated approval. So I'm not going to go into the details, but these were the preclinical studies which we did at Duke. We started in 1991, and we started doing the animal toxicity studies in 1997. In 1997, we also obtained what we call the orphan drug designation for Pompe disease. You first need to have that before you can proceed. And in those days, we did not have an animal model in terms of a mouse model. Today, you can generate a mouse model pretty quickly. So we knew of quail birds in Japan, and you can recognize here is an affected quail bird, and this is a normal quail bird. And so we now got eggs from Japan to Duke University and started the quail bird colony. And here is our proof of concept, is that if we provided the injection, this is the sham injection, and this is if you provide the actual enzyme, and this is the normal, non-treated animal or bird, you can see that after 7 injections with the enzyme, the bird is able to right itself, and in fact, some of the birds started to fly. So we had our first proof of concept that this enzyme treatment would work in a preclinical model of Pompe disease. And then we started with the clinical trials, and in those days, even manufacturing was challenging. So we did an open label study, single center study, only 3 patients. But again, my take-home message to you is that it's not the numbers, it's the quality of how you do research, and you can combine your clinical practice with research to get the data that you're looking for. So looking at this, we only had 3 patients, and out of the 3 patients, 1 of them did really well, and 2 patients were what we called non-responders. So despite them receiving the enzyme treatment and having an initial improvement, they started to decline. So I'm going to come back to this concept of how much we learned from the very first 3 patients. And so this was the baby that did well. This is baby Jason, and he's now 17 years old. And this is his affected deceased sibling at the same age. So this little one never received enzyme treatment, and this little one received enzyme treatment at about 2 months of age. So you can see a remarkable difference. And in the diseases at the extremes of disease severity, we don't expect any heterogeneity. So I would not have expected little Jason without treatment to have done any differently than his affected deceased sibling. So then after this phase 1 work was done, Genzyme obtained the licensing from Duke and Sympac, and then we went into phase 2 clinical trials, which I said now is the proof of concept in a larger number of patients. And then we also embarked on a natural history study. So for you in India, I really want to tell you, you have, I can say, a wealth of information that if you worked collaboratively together, you can provide natural history information for many, many parts of the world where we're trying to develop treatments and actually be part of this process. And then in 2003, we started the pivotal clinical trials with the enzyme, which today is marketed as Myozyme throughout the world. So the idea is that once Genzyme took it over from Duke, they started doing state-of-the-art manufacturing and then produced this product, and I'll go through the few steps of how this occurred. So when you're thinking about drug development, you really have to have an outline in your mind of how are you going to proceed. The most important is having a natural history or a comparator group, because any agency is going to say, how do you know this therapy works? And in some situations you can do a double-blind or a placebo study, but in a lethal disease like infantile Pompe, that's not ethical. So we did a natural history study, decided to start in infantile onset studies because of drug manufacturing, but also because of the lethal nature of the disease. And then we also laid out a map, of course, with our collaborators and Genzyme throughout the world for late onset, for an observational study, which is a natural history study, and then thinking about the clinical trials and what kind of endpoints would be used, and then doing the pivotal studies there as well. So So the idea is that the pivotal study, normally when we think about the field of any drug approval process, whether it's a statin or anything, it's usually in adults, and then we have a trickle-down impact in pediatrics. But here actually we had a reverse strategy where we showed the benefit of a therapy in the infantile population and were able to get broad label approval. So this one particular slide is a natural history slide, and you can see here this was a retrospective chart review from all over the world, with Taiwan, with I think some patients also from India, and you can appreciate that first signs and symptoms were at about 2.5 months of age, but the diagnosis for someone with infantile Pompe was 6 months, but by the time they died they were about 12 months. So there was a very short time for intervention if there was any. However, this particular study was a few $1 million, but it provided the proof of concept that if you do not treat, these babies are going to die, and that the median age of death is about 8.7 months. So if you do a well-conducted natural history study, the FDA or another agency will accept it, and that's what we used as we were doing our drug development program. And this is to show you an about 8-month-old with infantile Pompe disease, and you can see how floppy this little baby is, and this little girl succumbed shortly after this video was taken. So this is the natural cause of this disease. But now when we did the clinical trials, and I'm just going to zero in on the pivotal study, which was study 1, you can see that the mean age at when enzyme treatment was started was about 5.1 months in this study, versus another study which was more a compassionate use program. You can see some of these babies were as old as 15.7 months, a very advanced stage of the disease when they started on treatment. And this was the outcome from the 18 babies that we did in the clinical trial. And I want to show you, we had 7 children who learned to walk, 3 patients who learned to crawl and stand, 3 patients who learned to sit, and 5 patients who really had minimal gains. So once again, coming back, 18 patients all started at under 6 months of age, and we were seeing a variety of responses. So once again, the rare disease space, every patient counts. And we learned a lot, and I'll try and go through this with you. But this is what we had shared with the FDA of the kinds of motor outcomes we were now seeing with enzyme replacement therapy after 1 year of treatment. And if any of you, I'm sure you know, the natural history of this lethal disorder is children are not even able to sit. So there's no question of standing or walking or running. And so we were able to get broad label approval based on carefully collected data from a small number of patients. And this was another proof of evidence, the X-ray before and an X-ray after 12 weeks of treatment with enzyme replacement therapy. So once again, if you have a good concept and something that works, I think success can be yours. So now the other lesson that we learned is that for patients who were in study 1, so the ones who were started at a younger age as compared to those in study 2 who were started at a later age, you can already see that your risk of death is decreased in this younger group patients by 95% as compared to 79%. So if you start them later, you're not going to have a good outcome. And the likelihood of you being on a ventilator is much more if you start later as compared to if you start earlier. And so once you develop a treatment, very often people think that the job is done, but for us I felt that our job had just begun. Once again, you have to follow these patients. You've got to get a better understanding of the new natural history, because now you have treated patients that you never had any information on. You get insights into why one patient did better versus why a patient did not do as well. And then you can recognize that there are more phenotypes and more ways that these patients can present. So for instance, someone who comes to your clinic can come with a supraventricular tachycardia, and that can be a presenting sign for Pompe disease, or they can come in with a pneumonia and you do an X-ray and you find cardiomegaly, or they can have a hernia and code on the table as they're receiving anesthesia. So you keep learning more about the phenotypes as you understand them. And so when you see, and I'm going to tell you how wrong I was in this set of slides when I do my next set of slides, is I was very happy if I found someone at less than 6 months, and that was what we told all our Indian physicians. So this is a child who was in the early stages of the disease, as my understanding at the time. Of course, the child did relatively well and was able to walk, as compared to someone who was started on treatment in a little more advanced stage and could not really sit independently. So this child still remains alive. He's about 12 years old, but he's in a wheelchair at this point, versus someone here who was already on a ventilator and was very involved. And so although he continued to live 1 year into treatment, there wasn't really much of a treatment impact. So this is very clear that the later I treat someone, the more challenging it's going to be to have a good outcome for these patients. But then we also learned that what do you really call as early treatment? And so then I had the good fortune of a child who was started on treatment at 14 days of age, and you're going to tell me how did I figure this out? Because this little one's brother had died of infantile Pompe. So we started this child on treatment at 14 days, and now you can see that this child at 3 months, and then this child at 2 years, and then this child at 7 years, doing completely differently than someone who was, say, picked up at 5 months of age. So the concept of early diagnosis and early treatment started becoming more and more of a reality for us, and I'll come back and tell you how we've taken this again to the next level of developing newborn screening. The second is you need to understand histology, and so this is before treatment and this is after treatment, 6 months after treatment. And if you believe me, this is the presence of glycogen that's built up, and here you can see even after 6 months of treatment there's buildup of material, and this is autophagic buildup, which we never understood the concept of, and then Dr. Nina Rabin and others in the field have shown us that there's a role of defective autophagy. But then if you look at histology here, much more involved in this particular muscle or group of muscle fibers, and then 12 months post-treatment there's absolutely no change. So once again you can see that you initiate late in involved muscle fibers, you're not going to get the treatment impact. And then the third concept is you start looking at the muscle biopsy. You have some muscle fibers which are completely normal, and then you have some where there's accumulation of glycogen and others where there's more accumulation of glycogen. And similarly, in terms of treatment, some are responding better than others. So once again, going back to the basics, going back to a better understanding, working with the pathologist gave us more insights into management and improvement of treatment strategies. And now I'm going to take you to the next level. If you remember, I had told you about 3 babies, and 1 did well and 2 did not do well. So at that time, you know this, that to any foreign protein that you give someone, you're going to mount an antibody response. So Pompe disease has clearly paved the way for our understanding across the more common diseases as well. And this is the best if you don't make an immune response or antibody response. This is also acceptable if you have a downward trend and have tolerized, but this is not acceptable when you make an antibody response and you keep it. So we realized very quickly that if you don't make any enzyme on your own, then you're what we call cross-reactive immunologic material negative, and that kind of patient is not going to do well on enzyme replacement therapy. So this is on a Western blot. There is absolutely no protein. So when you administer the enzyme treatment, it is recognized by the body not as a self-antigen but as a foreign antigen. So once again, this concept came from those first 3 patients, because only 1 out of 3 was what we called cross-reactive immunological material positive, that is, had some residual enzyme or protein and had a much better response to enzyme treatment as compared to those who did not have any residual protein. And so now when we separated the patients by CRIM status, so when I say CRIM negative, there's no residual protein, you can appreciate that all these children did poorly, and they succumbed by about 27 months of age on a survival plot as compared to the CRIM positive patients. And then when you look at the antibodies, you'll see that the CRIM negative patients make very, very high antibody titers over a period of time as compared to someone who's CRIM positive. So they recognize the enzyme as a self-antigen and they tend to tolerize over time. So keep this concept, because now this has made its way into many, many other situations, including hemophilia, and including many other conditions where the models that we have learned from Pompe are being used. So this was that very first baby, and I thought I should show this to you. This is baby John, our very first patient, very first baby ever treated with enzyme replacement therapy. And I still remember this family because they said, Dr. Kishnani, you have unfinished work. You have to find a treatment for babies like my little baby John. And that was baby John at about 9.5 months on enzyme replacement therapy. And you can see that despite the enzyme, he was not doing well. And then we had this other baby who had come to us from South Africa. And this is the child who's now 9 years old and actually has celebrated his 13th birthday. Calls me regularly. He's got a hoarse voice. He's an active teenager and did very well, but he was CRIM positive and did not mount an antibody response to the enzyme. So the immune modulation, again, it taught us a lot because I had to now answer that family that I had promised that we were going to make a difference. And so I had to go back and learn immunology. And the idea is immune tolerance is the absence of making antibodies without a need for any ongoing therapeutic intervention and recovery of the B cells, which are the source of making these antibodies. And immunogenicity is defined as your propensity to mount an immune response to the therapeutic protein or to the enzyme. So here is, again, when you break it down to basics, here is the therapeutic protein, which is the enzyme. It's taken up by the antigen-presenting cells, the dendritic cells. It's broken down into smaller peptides. These peptides, then via MHC class 2, is taken up via the T cell receptors to helper T cells, then to the B cells, where there's this whole exchange going on, then the memory B cells, which store this in memory, that this peptide is a foreign peptide, and then the plasma cells, which we know is the final source of antibody production. So once again, looking at this made no sense to me, but my concept was, how does the enzyme not get to where it needs to? What is this antibody doing? And so the concept was clear. The antibody may block the enzyme therapy target cell entry. It may affect the catalytic activity of the enzyme, or it may facilitate the enzyme to go into the non-target sites. So let's look at this. This is the enzyme being taken up by the M6P receptor and going through the endosomal pathway into the lysosome as the process enzyme. This is what I really want. Now, if I have a problem because I've made an antibody here, the antibody can block the ERT target cell entry, so it's blocking it right at this level, or it can make it here, but